Welcome everyone to the Filipino Nursing Diaspora webinar on promoting lifelong cardiovascular health through secondary prevention and cardiac rehabilitation. Brought to you by the World Continuing Education Alliance. My name is Samantha, I work with the WCEA, and I will help you with any technical questions you may have in the chat. And for those of you joining us for the first time, WCEA is a social impact technology organization dedicated to using digital tools to help healthcare professionals grow their skills, improve care, and support healthier communities worldwide. If you have any questions for our speaker today, you are more than welcome to use the Q&A section, and we'll try to address any during the end of the session. And now I would like to leave you with our moderator today, Sir Dennis Amando. Over to you, Dennis.
Hi, good morning everyone. Magandang umaga po sa ating lahat. Good morning, good afternoon, or good evening, depending on where we are joining us from right now. I'm Dennis Amanda. I'm the Vice President for Engagement at the Pacific Nursing Service Organization, and it is my pleasure to be your moderator for today's webinar. Our session titled Promoting Lifelong Cardiovascular Health Through Secondary Prevention and Cardiac Rehabilitation, and it will be delivered by Dr. Dion Candelaria from the University of Sydney. As we all know, cardiovascular disease continues to be one of the top causes of death worldwide. But the good news is, through strong secondary prevention and quality cardiac rehabilitation, we can truly make a difference. We can help patients live longer, healthier, and more meaningful lives. In this webinar, Dr. Candelaria will guide us through evidence-based strategies and practical approaches that we can apply in both clinical practice and community settings. I'm sure we will all learn a lot from his expertise. This webinar is made possible through the partnership of the Filipino Nursing Diaspora, or the FiND Network, St. Anthony's College, the Pacific Nursing Service Organization, and the World Continuing Education Alliance. Before we begin, here are a few housekeeping reminders. The first is the webinar is being recorded. And then if you have questions for our speaker, feel free to type them into the Zoom chat box. With regards to the certificates, Sam will be making announcements about it later. So we are ready to start. Let's hear a few words to formally open our session. To deliver our opening remarks, we are pleased to welcome Dr. Aris Bungabong, Dean of the Nursing Program at St. Anthony's College in Antique, a strong partner in promoting academic and professional excellence in nursing. Dean Aris.
Good morning, everyone, from the Philippines and wherever you are joining us from around the world. Welcome to our Global Webinar Learning Series, and we are thrilled to have you all here for a truly vital session. Promoting lifelong cardiovascular health through secondary prevention and cardiac rehabilitation. This event is a testament to collaboration, and we are so proud to partner with the Filipino Nursing Diaspora Network, St. Anthony's College, the Pacific Nursing Service Organization, and the World Continuing Education Alliance. And of course, we are incredibly honored to host our distinguished speaker, Dr. Dion Candelaria, joining us all the way from Australia. As we know, cardiovascular disease is a global challenge, but today is about solutions. We are here to learn evidence-based strategies and practical approaches to help our patients live longer, healthier lives. Thank you for investing your time with us. Let's continue learning, leading, and saving lives, one heartbeat at a time. Enjoy the session.
Thank you very much, Dr. Bungabong. At this point, it is now my honor to introduce our distinguished resource speaker. Dr. Dion Candelaria is a nurse clinician, educator, and researcher at the Susan Wakil School of Nursing and Midwifery, Faculty of Medicine and Health at the University of Sydney. He is a cardiac registered nurse, and his work centers on helping patients reduce their risk of recurrent cardiovascular events by promoting secondary prevention of behaviors and strengthening access to cardiac rehabilitation. He completed his PhD in 2023, focusing on how cardiac rehabilitation service delivery characteristics influence patient-centered outcomes. Drawing from extensive clinical and academic experience, Dr. Candelaria is committed to advancing long-term cardiovascular health through evidence-based, person-centered strategies. He advocates for holistic, accessible care and integrates global perspectives with practical approaches that empower both healthcare providers and the patients they serve. Let us give a warm virtual welcome to Dr. Dion Candelaria.
Thank you. Thank you so much for that very generous introduction. Thank you. And thank you for having me. I'll share my screen now. Does that work?
Yes.
Yeah, okay, perfect. All right, so once again, thank you for FiND Network for organizing this webinar and for inviting me. It's my pleasure to share a little bit of my experience and expertise in cardiac rehabilitation, especially for this particular webinar about promoting lifelong cardiovascular health through secondary prevention and cardiac rehab. So I have left my email address on the screen in case you'd like to follow up or ask anything, but feel free to use the chat function or the Q&A function. All right, let's go. So I always would, so I'd like to start by a patient story. So this contextualizes the talk. So I'd like you to meet Maria. Yeah, so Maria is a 62-year-old woman who works casual shifts at a retail store. She lives with her partner and is the primary carer for her 88-year-old mother. English is her second language. She has hypertension and high cholesterol, but often forgets to take her medications when life gets busy. One morning while getting ready for work, she felt shortness of breath. At this point, it's not even heart, it's not even chest tightness, it's only shortness of breath. But she tried to push through it, thinking it was stress. So her partner insisted on calling an ambulance. She was diagnosed with a non-ST elevation, MI, and was taken for urgent management. So during her hospital stay, she kept saying things like, "I don't want to be a burden," and "I'm hoping to go back to work soon." So she was anxious, visibly overwhelmed, but didn't ask many questions. So this is what we're going to answer later on is how can nurses support someone like Maria to recover, stay healthy, and feel confident after a cardiac event? So we'll go back to Maria's story at the end. So the outline for today's talk is going to be about cardiovascular disease and secondary prevention, what cardiac rehab is, the evidence of the benefits of cardiac rehab, the nurse's role across the patient journey, and as some of you may be allied health professionals or medical professionals, so I guess we can then expand that role to the role of health professional across the patient journey. And lastly, I'd like to tackle some misperceptions around cardiac rehab. So we only have an hour. I usually give these type of talks for I guess for much longer, but that's okay. We'll make it we'll make it work. So first of all, why should we care about this topic? We care about this topic because, as what was introduced, is cardiovascular disease is the world's #1 cause of death. Okay, and it has been for a while. So 18.6 million deaths every year are from cardiovascular disease, and that accounts to 33% of all global deaths. And it's very notable that more than 75% of these deaths take in low middle income countries. So there is a gradient, there's a socioeconomic gradient with cardiovascular disease where it affects low socioeconomic status in low middle income countries a lot more. And it has to do with the health systems within these countries as well. So if we would compare cardiovascular disease to other disease conditions, as I've said, 18.6 million would account for cardiovascular disease, and that's compared to 10 million for cancer, 3.7 million for respiratory diseases, and 1 million for HIV. So of course, this is not a competition, but you can see the gap between CVD and cancer, for example. So again, this next slide, I just like to show you the prevalence of cardiovascular disease. So the deeper the red color is, the higher the prevalence of cardiovascular disease. And as you can see, it is widespread all over the world, but in certain parts, I guess, North Africa, the Middle East, the Sub-Saharan, subcontinental Asia, and Southeast Asia are a bit more, affected, and they're deeper in color. And in these circles, it it shows, or they at least tell us a little bit of the reasons why. So, for example, for Russia, they attribute that to high rate of smoking, um, and and in China, for example, it's a bit more pale because of the high vegetable intake in that country. So later on, I'll talk about the risk factors and things. So before we go any further, because this is going to be a heavy cardiovascular disease and recovery from heart condition, I'd like to give you a little bit of background about coronary heart disease, coronary artery disease, or ischemic heart disease. They're all the same. So your coronary arteries deliver blood and oxygen to your heart muscles. Okay, so when you have and the inner lining of your coronary arteries are supposed to be smooth. So in the case of coronary heart disease, there is a plaque buildup in the coronary arteries, and this plaque is made up of cholesterol, calcium, platelet debris. And what happens is that plaque over time increases and obstructs the blood flow to the different heart muscle. Okay, so as you can see here, that the lumen of the blood vessel is wide, and here the plaque kind of restricts or narrows the coronary artery. The result of that is the heart muscle doesn't get the blood supply that it needs and the oxygen that it needs. So therefore, there is ischemia. There's lack of oxygenation to the muscle, and if that persists, then the heart muscle dies and loses its function. So that's why it is very important to manage a heart disease. So we have non-modifiable risk factors. So these are the risk factors that you really can't do anything with. So risk factors for heart disease that are non-modifiable include age. As you know, as you increase age, as you get older, your risk increases. So sex before the age of 60, men are at greater risk of developing cardiovascular disease. But then when women enters into menopause, then the risk balances out, that the men and women would have a similar risk. So family history as well as ethnicity. So individuals from African or Asian ancestry and indigenous populations are at higher risk of cardiovascular disease. But as I've said, these are the things that we can't do anything about. So I guess we should focus then our energy more on the modifiable risk factors. So these are the risk factors that we could control, that we could address, or that we could do something about to reduce our risk. So we have smoking, a high cholesterol, high blood pressure. So smoking, because it's a potent vasoconstrictor, and high cholesterol and high blood pressure. Again, high cholesterol because the plaque is made up of cholesterol. So the higher the cholesterol in the blood, then the higher the affinity to these plaques. So high blood pressure creates minute tears in the blood pressure, then making the endothelial lining more amenable to atherosclerosis. You have diabetes, physical inactivity, overweight, and unhealthy diet. But also, I'd like to emphasize mental health issues, particularly depression. So, depression and other mental health issues have a bi-directional relationship with cardiovascular disease. So, what does that mean? It means that patients who have cardiovascular disease, or sorry, patients who have mental health issues are more prone to developing cardiovascular disease. And for patients or for people with cardiovascular disease, they're also more prone to developing mental health issues. So it's a cycle that needs to be broken. Um, and in recent years, the spotlight has been kind of shown on the effects of loneliness. So social isolation, I guess in our modern, age of technology, social isolation is a risk factor for developing cardiovascular disease, social isolation and loneliness. So why does this matter? So this matters because 10% of acute myocardial infarction or heart attack survivors will have another cardiac event within the first year and 20% within 3 years. So the thing with these repeat events is that these are largely preventable. They're largely preventable by controlling the risk factors that I've just mentioned. Now, what we need is stronger secondary prevention strategies. Now, for some of you that are working in public health, so secondary prevention in the public health context may be a little bit different because in public health, secondary prevention refers to screening and prevention in that way. But in preventive cardiology, when we say secondary prevention, what we talk about really is the prevention or reducing the likelihood of repeat events. So primordial prevention is maintaining health overall, avoiding risk. Primary prevention is reducing and eliminating the risk. And secondary prevention is reducing the likelihood of the event happening again. So secondary prevention is aimed for people with established coronary heart disease or who had a coronary heart event, and the goal is for that to not recur. And that's where cardiac rehabilitation comes in. So I will read to you, and later on we can unpack the definition of cardiac rehab from the World Health Organization in 1993. So I would like to point out that this is a little dated in terms of a definition, and I am part of the World Heart Federation roadmap in cardiac rehab, where we are defining or redefining cardiovascular rehabilitation, but that is currently in the process of being published. So it's not out yet, but anyway, you can watch out for that. So cardiac rehab is the sum of activities required to ensure patients with cardiovascular disease the best possible physical, mental, and social conditions so that they may, by their own efforts, resume and maintain as normal a place as possible in the community. So then the British Association of Cardiovascular Prevention and Rehab extended that definition to include and through improved health behavior, slow or reverse the progression of disease. So that is, that is a big paragraph of definition, but let's unpack that. So cardiac rehab is a sum of activities, which means it's not one thing. It's not a pill that patients can take. If only it were a pill, then everyone's well and good. But no, it is a complex intervention composed of many different things, components, many different strategies delivered by a multidisciplinary team over a period of time. So that in itself makes it complex. And it is geared towards ensuring or providing patients with the best possible physical, mental, and social conditions. I guess this part of the definition of cardiac rehab is tied to the World Health Organization definition of health. So when they came up with a definition of health, that was then kind of followed through in all of the other definitions that they produced. Now, the next thing is the emphasis of by their own efforts. So the patient has to initiate these efforts. So we can't stop smoking for someone. We can't take their medications for them. We can't exercise for another person. So really, our role as healthcare professionals is to empower, to educate, and to provide them with the conditions to adopt the healthy behavior that we want them to adopt. But of course, behavior change is not easy, and behavior change can be a whole topic altogether, a whole webinar, and a whole course altogether. So we'll touch on behavior change somehow, but we won't kind of go deep in the principles of behavior change. The next part of the definition is that they may resume and maintain as normal place as possible in the community. So this is what shows that the definition is so 1993. That's because during that time, cardiac rehab, the main aim of cardiac rehab was for people for men really to go back to work. So there was a strong emphasis of return to work. But now it's not just for them to be able to return to work. It's for them to reduce their risk of dying, for the patients to feel better, to improve their quality of life. There's so much more to it rather than just being able to reintegrate in the society. Now, with the BACPR, I think they emphasize the health behavior side of things, that for you to be able to achieve these things, there needs to be a change in behavior, or at least an improvement in your current behavior. And they went they went a little bit more medical, I guess, that the whole point of that is to slow or reverse the progression of disease. So uh, um, coronary heart disease is a chronic condition, and what you need to do when you're modifying it is to slow or reverse its progression. So that is kind of what cardiac rehab is. But again, there's still a lot of components to it. So this is a kind of a by the way slide. So cardiac rehab has generally 3 phases. And it starts when a patient is hospitalized. When a patient is in person, there's phase 1. Now, the cardiac rehab program that we know or that we talk about is usually phase 2 cardiac rehab. So when you hear cardiac rehabilitation program, usually what is meant is the outpatient cardiac rehab, which is usually 8 to 12 weeks program of comprehensive secondary prevention. It tackles all of the risk factors. There's individualization. It's delivered by a multidisciplinary team. But then, and this has been this is becoming my focus in my research and in my career, is that cardiac rehab shouldn't or the changes that patients do shouldn't be confined in those 8 to 12 weeks. That it should be a lifelong journey. And that's why phase 3 is very important, which is the maintenance phase, where the patient is empowered and they do their health behavior on their own, unprompted, and kind of integrating it into their lives. So this is just for us to keep in mind that there are 3 phases, and cardiac rehab on its own is phase 2, is usually what we say. Now, as I've said earlier, there are a lot of components for cardiac rehab, and so these components are patient assessment, nutrition counseling, weight management, blood pressure management, lipid management, diabetes management, tobacco cessation, and in recent times, tobacco and vaping, psychosocial management, physical activity counseling, and exercise training. So traditionally, cardiac rehab is exercise-based, but we are slowly moving away from a heavy exercise focus, and we are giving, I guess, an equal footing for all of the other risk factors to be addressed, because exercise isn't everything. There are other risk factors that you need to address for you to have for you to reduce your risk. So I guess you could clump, or you could categorize these core components into patient assessment, exercise training, psychosocial support, very important, risk factor modification. And the way that these risk factor modification is delivered is through patient education. So you have nutrition counseling, weight, medication adherence for blood pressure, lipid, and diabetes, for example, tobacco cessation, and physical activity. These are delivered through patient education and empowerment. And it's not simply didactic patient education. You would have, motivational interviewing. There is a personalized approach in providing the information, and also taking into account patients' health literacy, or in this modern world, e-health literacy, because a lot of the time we provide patient education to patients using different modalities. It's not only a brochure, for example. You can provide links for credible sources of information. You can provide videos. So if there are these modalities, you need to ascertain a patient's health literacy and digital health literacy. So, all right. So now, hopefully, I've kind of introduced cardiac rehab to you and what it is and what it includes. Let's now go to the evidence. So what is the evidence? So in front of you is the latest Cochrane review of 85 randomized controlled trials involving 23,000 participants and a median follow-up of 12 months. So they looked at randomized controlled trials where they compared exercise-based cardiac rehab versus no cardiac rehab. And what they found is that at 12 months, patients who attended cardiac rehab has 26% less likelihood of death from a cardiovascular cause. So risk ratio of 0.74 means that there's 26% less likelihood to die from a cardiovascular cause. So right, okay, so patients don't die from a cardiovascular cause if they attend cardiac rehab. Great. But how about their quality of life? So this is one of my papers during my PhD where I looked at patients' health-related quality of life for those who attended cardiac rehab and for those who didn't. So I looked at 14 randomized controlled trials from year 2000 onwards. So we're looking at a contemporary or a modern cohort of patients. And what I found was that cardiac rehab improves physical performance and general health at 6 months and overall physical functioning, even in the long term at 12 months. So great. So there's evidence for people not dying and for people feeling better. Now, the next one is an interesting one because they compared, instead of cardiac rehab and no cardiac rehab, they compared cardiac rehab cohort to a cohort of PCI or stent. So that is when they insert a stent to open up the clogged artery. And what they found was that cardiac rehab is better than PCI for all-cause mortality, rehospitalization, and cardiovascular morbidity. So therefore, not because your arteries were opened up and that your heart is getting blood and oxygen again, you're fixed. In fact, that's just the start of a lifelong journey that you need to do in terms of maintaining your health and keeping on top of your health. So, so I guess this one is interesting in a sense that it kind of demonstrates that there's no simple fix for heart disease. So you may have a fix, but it needs to be coupled with an ongoing effort in terms of reducing your risk factors and managing your health. So the next slide is about the dose of exercise. So the bottom line is there is a dose response benefit, meaning the more the better. The more exercise you do, the better. Although there is also a saying in the exercise world that something is better than nothing. Okay, so instead of going, instead of thinking blue skies and being pressured to have a lot of exercise, a little something is better than nothing, but more is better than some. So I guess that's how I would summarize this. Now, if you take into account all of those evidence, then you should be convinced at this point that cardiac rehab is important. So therefore, let's talk about guidelines. So international clinical guidelines for the management of acute coronary syndrome, and I just picked the main one. So this is the 2023 European Society of Cardiology, recommends cardiac rehab that recommends cardiac rehab for all patients with acute coronary syndrome, that they participate in a medically supervised, structured, comprehensive, multidisciplinary, exercise-based cardiac rehabilitation and prevention program. So they provided a class 1A level of evidence. So the American Heart Association also recommended cardiac rehab for all ACS patients. And again, it's also class 1A. Now, the 2025 Cardiac Society for clinical guidelines for diagnosing ACS in Australia recommends that for all ACS patients that they be referred to multidisciplinary exercise-based cardiac rehab, and that they get provided lifestyle advice, healthy eating, regular physical activity, all the things that we have talked about. Right. But what does class 1A really mean? So class 1A is a strong recommendation and applies to most patients in most circumstances without reservation. So grade 1 recommendation, I guess, is the strong recommendation, and grade A means that the source of information come from consistent, well-performed, high-quality randomized controlled trials with overwhelming evidence. So there you go. So cardiac rehab, in reality, it should be a norm. Everyone should be everyone that has a heart condition or comes in for hospital for a heart attack should be referred to cardiac rehab, but that is not the case. The main problem with cardiac rehab is participation, and we're struggling with participation rates. And that is because of a lot of barriers. Can't go to the hospital, I feel well enough, or no one told me, I wasn't referred, or in some parts of the world, there isn't a cardiac rehab program. So, and this is why, the cardiac rehab community is very passionate in moving this forward, because A, it is very important, but also B, there's a lot of gaps that we can improve on. Now, if you are interested, I've put in a couple of resources. If you are interested to know more, the nitty-gritty of the program, exercise prescription, or Mediterranean diet, or whatever you want to explore, there are resources you can check. There's a BACPR handbook, or I think it's a book. There's a guideline for cardiac rehab by the American Association of Cardiovascular and Pulmonary Rehab, AACVPR. And also, wherever you are in the world, you would have a heart foundation in your country. They usually have resources that you can check out if you want to know more. And if you don't have your dedicated heart foundation in your country, World Heart Federation is kind of like the parent heart organization for the world. Now let's move tack a little bit. Let's move tack a little bit and talk about the nurse's role across the patient journey. So I guess I understand that not everyone is a nurse. So let's say the role of the healthcare professional in the patient journey. So in the acute phase, we need to early mobilize the patients and provide basic education. This includes explaining the event, the medication, and the next steps. So what I expect for acute care nurses is to at least have the starting conversation about cardiac rehab or risk factor management. Okay. You have to introduce cardiac rehab in a clear, reassuring way, and also introduce it as a normal part of the cardiac continuum, that you were hospitalized for this, the next phase is this. And I say that because not all healthcare professionals are singing the same song in terms of recommendation. I still hear up to this point that our medical colleagues or cardiologists, once they, especially the interventional cardiologists, when they put a stent in, for example, then okay, there you go, you're fixed. Just take your meds and you'll be fine. But the reality is that's not true. The stent is not a fix; it is the start of a lifelong journey, uh, and sometimes the patients have that misperception because it's reinforced by other people. And what we need to do as healthcare professionals is to deliver the same message of, right, so this is what the next step is. You need to go to cardiac rehab, or have you thought about going to cardiac rehab? And making sure that they have the information they need. You also answer some questions that they may have. This is also where you identify psychosocial concerns, because psychosocial concerns are a big barrier for patients to adopting healthy behaviors. And a good way to do that is to involve family or support people, because in the inpatient or in the acute phase, the patients might not have the mental capacity to take on all the information. They're still recovering. There might be a shock involved, of if it was a sudden cardiac event. They might be worried about the future. There's a lot of things going on. So it's good to involve the family and support people in your interaction and in your education, so they can then as well reinforce the message. Now, before the patient goes home, during the discharge planning, make sure you have a referral. If you have somewhere to refer to, then well and good. Make sure you check patient's understanding and readiness. You explore barriers, transport, work, caregiving, language. Make sure you explain and provide plain language materials if they need to, if they want to. And as I've said earlier on, you can direct them to resources, to websites. You can provide them with brochures if you have it. There's so many things that we can do. And also coordinate with the cardiac rehab team and the GP. And that is if you're working in a hospital that offers cardiac rehab. So I understand that might not be the case for all of the hospitals too. Now, during the outpatient programs, and this is where this is phase 2 that I was talking about, the outpatient cardiac rehab. This is where goals are reinforced, and medication adherence is also reinforced, because they're going to be on medications forever. They're going to be on lifelong medications. Outpatient cardiac rehab programs are usually exercise-based, but the exercise is tailored to the patient's capacity, or at least it should be. But not only that, there's also, as I've shown earlier on, there's also a lot of risk factors that are addressed during that period. There's monitoring of symptoms and progress, there's motivational conversations, and these are not lectures. These shouldn't be purely didactic. These are motivational conversations, addressing concerns if they have any questions, addressing misperceptions if they have, if they heard from their neighbor or if they saw on Facebook, things like that. There's a lot of information that the patients could access. So sometimes the problem is sifting through the information and knowing what is credible and what is not. And I guess they would look up to us as healthcare professionals to be the source of that, or at least to know where to direct them to. During that 8 to 12 weeks, there's also screening for depression and anxiety. And if they screen positive for depression and or anxiety, that they should be referred to a professional help. So they could be referred to a psychologist or a counselor, for example. There's also a lot of screening during this program. So you can screen for smoking and again, then refer to a smoking cessation helpline or support of some type. So it's important to celebrate small wins to build confidence. And this is part of the self-efficacy building for your patient, that when they achieve something, they feel empowered to keep doing that. So that's what happens during the program. But then you don't want that to stop, and you want that to continue. So the long-term support is aimed at enhancing a patient's independence in managing their own health. So long-term support includes encouraging lifelong physical activity, continued monitoring in primary care setting, make sure they attend the GP, they go to the GP for a follow-up check every 6 months or every year, however long it may be. Make sure you reinforce healthy coping strategies and mental well-being. And the last point is very important, especially nowadays, that the patients need to be, I guess, referred or linked to community programs or peer support groups, because there's a lot of good things that happen within a group setting, and peer support is also very powerful. So these are the role of the healthcare professional across the patient journey. Make sure to take time to have a look and make sure you include that in your practice if you're not doing them yet. Now, we are kind of towards the end. I'm just looking at the time. I'm going okay with time. So I just like to show you the myths versus reality. And you may have some of these misperceptions as well, so it would be good to discuss. So one is cardiac rehab is just exercise. No, it's a comprehensive program of education, support, and risk management. Number two, patients can just exercise at home instead. Well, yeah, but supervised and structured programs ensure safety and addresses all lifestyle and medical risk factors. So it's not just being able to exercise, it's being able to exercise safely and well. Number three is only elderly or frail patients need rehab. No, cardiac rehab is for everyone with heart disease, as I've said. Young working adults also benefit greatly from cardiac rehab. And also, because it's not only exercise, they may not benefit from the exercise because they're already fit physically. But maybe their mental health isn't addressed. Maybe their diet and nutrition, they don't know how to plan their meals, for example. So there's always something for everyone in that comprehensive package of program. Only stable or fit patients, this is, I guess, the flip side, that only stable or fit patients can do it. No, it is tailored to every person's level of ability. Now, if the procedure went well, procedure meaning the stent or an operation, well, rehab isn't necessary. Well, as I've been hammering from the start of this talk, that it is a part of recovery. It should be a normal part of the care continuum. And that's because there is strong evidence behind it, and it reduces complications, improve long-term outcomes, and prevents hospital readmissions. Now, doctors handle referrals. Uh, yeah, but nurses also play a key role in recommending and referring. And in some health systems, the nurses can initiate the referral. But I do understand that in many healthcare systems that they do need a doctor's referral for a cardiac rehab program. But definitely nurses and allied professionals can advocate for that. Now, the last one is it's the cardiac rehab team's job. No, it's all of our job. And that is my message for everyone, that it is everyone's job. If you can just plant the seed, or if you can advocate for it, then the better. Now, I just want to show you, this is one piece of writing I wrote for the Journal of Cardiovascular Nursing. And you can, and I can send the link. I didn't put the link here, but I can share it with you. And a part of it says that strengthening cardiac rehab education and engagement across nursing roles empowers nurses to advocate for patients and champion secondary prevention throughout the continuum of care. So again, this is me advocating that nurses, whether you are in acute care, whether you are in community, wherever you are, even if you're not a cardiac care nurse, these are things that you should know so that you can advocate properly for your patients and you can strengthen secondary prevention and cardiac rehab. Now, before I close, I'd like to share that one of my many hats that I wear is that I'm the secretary of the International Council of Cardiovascular Prevention and Rehab. So we are a council, we are an organization of organizations. So our members are national organizations of cardiovascular prevention and rehab in each country. And I just thought that the Let's Talk ICCPR podcast that I host might be of interest to you. So I was going to share a QR code, but I didn't have time. So you can visit Let's Talk ICCPR podcast.buzzsprout.com. So we've just wrapped up season 1. I've had 6 guests so far from each of the World Health Organization region. I've had a guest from Brazil, the UK, Pakistan, Kenya. Oh gosh, where is the other one? Australia, of course, and also India. So, oh, did I have any? Anyway, so check it out and see. You might learn one thing or two. And now, where is Maria now? You might wonder. Now we've supported well. The nurse explained cardiac rehab clearly and offered her options. Now the team helped her organize transport. She was given education in plain language. She was given translated materials because English is her second language. She felt listened to. She wasn't judged. She gained confidence. She returned to work in the end, physically stronger. BP and cholesterol were well controlled. Now, what happens if she isn't supported well? So cardiac rehab was handed to her in a pile of discharge papers. She didn't know what to do. No one asked her about transport. She assumed cardiac rehab was only for the fit, so she never enrolled. Her medications were not reinforced. She resumed old habits. At 3 months, she's back in the emergency department with unstable symptoms due to poor adherence and anxiety. So I guess the bottom line of this is you have the capacity and you can influence whether she goes to the green side or she goes to the red side. My key takeaways for you are cardiovascular recovery is a lifelong journey and not a single event. Nurses and healthcare professionals shape that journey through education, advocacy, and compassionate support. And equitable and person-centered cardiac rehab and second prevention can change lives. Thank you very much for your attention. And I guess we're opening up for questions. Do we have time?
Yes,
Yeah.
let's do that.
Thank you very much, Dr. Dion Candelaria, for the insights. Very insightful and evidence-based presentation. I'm sure many of us here, whether from the clinical practice, academia, or community health, have gained valuable takeaways that we can apply in our own settings. At this point, we will open the floor for your questions. So if you have questions, please type it into the Q&A panel and we will address as many as we can. At this point, I think there are several questions already in the Q&A panel. So can Dr. Candelaria see the questions? I can also read it for you, sir.
Oh, sorry. Yeah, okay. I'll have a look. So from hang on, sorry. From Mohammed, what are the most effective evidence-based strategies for healthcare professional to practically implement and optimize patient adherence to secondary prevention protocols and cardiac rehab programs in real-world clinical setting, especially for vulnerable populations? Practically implement and optimize patient adherence. So this is a loaded question. Okay, so I think I think for a start, the important the important is that you start that conversation. So have that conversation, plant that seed, identify the barriers, and you can then refer the patient to a cardiac rehab program that is, within, that is feasible for the patient to go to, for example. Okay, so I guess that's my take on that, and that's, in a real world practical setting. What ethnicity is mostly affected by heart diseases? So as I've said, um, so the South Asian population are at high risk of heart disease, but that's, I guess, by way of hypertension. There's a high rate of hypertension. Um, uh, African ethnicities also a high risk of heart disease, and indigenous populations are high risk of heart diseases. So given that sub-Saharan countries may have higher temperature than other popular CVD countries, but can we know the exact date of CVD percentage, because we encounter more cases of cardiovascular disease nowadays? Can we know the exact date of CVD percentage? I think so. There is every year there is the Global Burden of Disease report from the GBD study, and I don't have it in front of me, but that group releases the percentage of, or the prevalence of cardiovascular disease and the incidence. So incidence are the new cases, and prevalence is, who has the disease altogether. So Mohammed, I would also encourage you to go to World Heart Federation website. They would have like a map, and they may have more information there in terms of a world data. From an anonymous attendee, how many times do we have to exercise per week in order to have a healthy heart? Very good question. So the recommendation is at least 3 times a week of moderate, vigorous physical activity. So three to five. I mean, I guess at least 3 days of moderate, vigorous physical activity, for you to have a healthy heart. From Crisia, what innovative strategies can be implemented to promote lifelong cardiovascular health through secondary prevention and cardiac rehabilitation? So I guess the innovation that we're doing now is to make it more accessible. So for example, there are text messaging as an innovation, simple but low cost innovation, for example, of text messages being sent to people with heart disease to remind them, of, you exercise, or eat a fruit or something. So there are strategies like that that were proven to be effective for, I guess, prompting and ensuring adherence. From Jana, how can secondary prevention strategies and structured cardiac rehab programs work together to promote lifelong cardiovascular health and reduce the risk of recurrent? How can secondary prevention strategies and structured work together? Yeah. So I feel like I've answered that in the whole of the presentation. So these are all strategies that work together. It's a comprehensive package of, mental health, addressing mental health issues, addressing diet and nutrition, um, physical activity counseling, all of those things will just work together to promote lifelong cardiovascular health. How can technology be used to improve access to and effectiveness of secondary prevention and cardiac rehab programs, especially in remote areas? Very, very good question. So technology, as you know, is both a friend and an enemy. So in a lot of ways, like what we're doing now, like this webinar would not have been possible with, however, 500 people in one room without technology, right? So it increases reach and access for some people, but also it causes a divide for some people who can't access that technology. So um, during my PhD, for example, I was doing PhD during COVID, and that's when everything went online. What we found was, yes, the Zoom version of cardiac rehab was able to reach a lot of people, but also the groups of people that were attending in person versus those that are attending online were different. So, for example, a specific example that we found was the ethnic minorities or people whose English is a second language. Of course, we're in Australia, so English is like the main language. There were significantly less. There were significantly less participants in the online version, and that's because if there's language barrier, it is hard as it is in person. It would be even harder, for example, in a remote uh, uh, a mode of delivery. So yes, technology can be used, but also be very careful to not exclude some people who can't access that technology is going to be my response. If I walk 2 kilometers to work every day, is that enough for my cardiac health? Okay, so I am not an expert in exercise as it is, so this might be a little bit technical, but incidental or occupational physical activity is different from a, uh, a a deliberate exercise. So if you walk 2 kilometers, you don't reach that heart rate of a vigorous exercise, if that makes sense. So for James, that's good that walking 2 kilometers every day, but I guess for you to achieve like the heart healthy effects, there needs to be that kind of heart rate increase and the vigorousness of the activity. But good job for doing your walks. Oh my God, there's a lot more. Okay. My question is, what happens to cardiovascular disease as a person ages? So there's many things that happens when a person ages. The arteries become stiff. They're not as flexible. So there's higher rates of hypertension, then there's higher chances of a atherosclerosis happening. There's also higher chances of comorbidities as a person ages. And then there's frailty syndrome. There's a lot of things that happen when a person ages that can be compounding, the effects of cardiovascular disease. And what barriers commonly prevent patients from completing cardiac rehab, and how can healthcare providers address these barriers? Very good question, Shahana. So the barriers are well known in terms of patients not attending. A lot of it are due to transport issues, caregiving issues, return to work, like they need to go back to work. They can't miss a day, for example, because obviously that would have impacts on their employment and their livelihood. And how can healthcare providers address these barriers? So one of the things that we do is to change the mode of delivery. So that's what I was talking about. If you can do a home-based or Zoom-based video conferencing, that might be a good help. And two more. What roles the cardiac and preventing confidence? So I feel like I've covered that during the talk. There's, patients regain confidence because they're in a group environment. They learn about other things. They exercise. So that makes them regain their confidence. and then this is skipping about 100 times. Is James the same person that walks 2 kilometers? Oh yeah, he is. Okay, well, sure. Okay, yeah, skip 100 times. That's good. What type of moderate exercise do you suggest for prevention? So there is no, I guess, specific type of exercises for as long as you can choose what you want. You can skip, you can row, you can choose your sport for as long as you have that moderate to vigorous physical activity, then it would be good for you. Thank you so much.
Thank you.
A lot of
Thank you.
engagement there.
Yeah, massive engagement from our participants. But before we wrap up, Dr. Dion, I have a quick question for you also,
Sure.
because I believe there are a lot of nursing students who are also joining the webinar.
Okay.
So, what practical strategies can nursing students use to ensure safe and effective continuity of care for cardiac patients transitioning from hospital to home and into community-based rehabilitation programs?
Okay, can you repeat the first half of that?
What practical strategies can nursing students
Yeah.
use to ensure safe and effective continuity of care for cardiac patients transitioning from hospital to home and into community-based rehabilitation programs?
Okay, I think one of the things that nursing students have and clinicians don't have a lot of the time is time. Okay, so as nursing students, you have the time to sit down with your patients to understand their situation, their context, and what they can and can't do. So I guess in the most practical sense, what you can do as nursing students is to spend time with your patients, understand them, and then guide their thinking and provide them with the education that they need. And the education that they need would be different for each patient. So for example, there's one that walks 2 kilometers. So maybe tell them to, eat fruits and vegetables or something, reduce their salt content in their meals, for example, or identify the barriers that would prevent them from adopting the healthy behavior and see if you can work around and address those things. So I think uh, if you can do that, uh, then I'd be very happy because a lot of the nurses would be running around understaffed, overworked, you know what it is. So as nursing students, sit down, talk to your patients, provide education.
Wow, thank you. Again, thank you very much, everyone, for the active participation and thoughtful questions. And of course, our deepest gratitude to Dr. Dion Candelaria for generously sharing his expertise with us today. At this point, we are moving towards the end of our session. So to formally close our session, we may now welcome Dr. Patria Manalaysay, the President of the Pacific Nursing Service Organization, to share her closing thoughts.
What a powerful and enlightening session we've had today. On behalf of the Pacific Nursing Service Organization, I extend my heartfelt thanks to Dr. Dion Candelaria for his brilliant presentation on promoting lifelong cardiovascular health through secondary prevention and cardiac rehabilitation. His expertise reminded us that heart health is not only a clinical priority, but a lifelong commitment, and that nurses are at the center of empowering patients and communities to live longer, healthier lives. Dr. Candelaria's insights serve as a timely call for us to strengthen cardiac rehabilitation programs, especially in underserved and multicultural populations where prevention is vital. His message resonates not only in Australia, but across the Pacific and beyond. I would also like to express my deepest appreciation to our partners, St. Anthony's College, the Filipino Nursing Diaspora Network, and the World Continuing Education Alliance for their unwavering support in bringing today's learning event to life. As we close, may we be reminded that leadership in nursing is expressed through education, advocacy, and compassion. Let's continue to collaborate, educate, and innovate for the heart of our communities. Maraming salamat and see you at our next session.
Thank you very much, Dr. Manalaysay. Indeed, this session reminded us that promoting lifelong cardiovascular health is truly a shared responsibility, one that requires evidence-based practice, strong advocacy, and continuous collaboration across healthcare and communities. At this point, we would like to extend our thanks to our partners for making this webinar possible: the Filipino Nursing Diaspora Network, St. Anthony's College, Pacific Nursing Service Organization, and the World Continuing Education Alliance. To all our participants across different regions and time zones, maraming salamat po. Thank you for spending your time with us and your commitment to improving cardiovascular health. On behalf of our organizing partners, this is Dennis Amando from the Philippines. Stay well, stay inspired, and may we all continue championing the heart health in our communities. Have a wonderful day, everyone. Maraming salamat po.
Thanks, everyone. Bye.